Next speaker is Dr. Jon Lambert. He's a doctor, MPN specialist at UCLH, and he's, as Adam said, is going to come talk to us a little bit about skin cancer. Thank you very much.
Morning, everybody. Thank you, John. Thank you for the invitation to speak here. I recognize a few of you. So my name is Jon Lambert. I'm a hematologist at UCLH in London. And Adam's talk actually segues very nicely into mine because, as he mentions, the Mithridate study, which is a very important study looking at the role of ruxolitinib up front for people who've got polycythemia vera, so it's the first-line treatment. What I'm going to talk about towards the end of my presentation is a sort of an offshoot or a sub-study, as it's called, which is looking at the issue of skin cancer. And a few years ago, you might have thought, what skin cancer got to do with MPN? It's a completely different organ, there's nothing to do. But actually, I think increasingly we're aware of the risk of skin cancer, particularly related to certain treatments, but not just related to MPN treatments. So what I'm going to do is just talk you through a little bit of the evidence kind of behind the risk of skin cancer for people who've got MPNs, and then just talk briefly about the study itself, the sub-study. So MPNs, I think we're all fairly familiar with. These are the three main ones, ET, PV, and MF. And then these are the skin cancers we're talking about. And predominantly, actually, we're going to be talking about what's called the non-melanoma skin cancers, squamous cell carcinoma and basal cell carcinoma. These actually are relatively common. They're some of the commonest cancers in humans, and they get more common as you get older. Generally, they actually have quite a sort of a favorable outlook, often just by removing them surgically. That's all you need to do, and they don't come back, and they don't cause longer-term problems. But what we have seen, what I've seen, and I think colleagues around the country have seen, is that people who've got MPNs, sometimes even with the more, so what we tend to see is a kind of the more sort of indolent end of this sort of skin cancer spectrum, they can behave in a slightly more aggressive kind of way. So that's really what underpins the question that we're asking in this Mithridate sub-study. So I'm going to talk a little bit about the link between MPN and skin cancer and whether there's any particular people with MPNs who are at particularly higher risk, and then a little bit as well about, if you do develop a skin cancer, what to do about it. So I think there is definitely a link between skin cancer, between MPN and skin cancer. This was a European study led by the Italian group, and it looked at these Swedish health registries. And the thing about Swedes and Norwegians and Danes, they've got really comprehensive healthcare records, and they can basically look up for the whole country, who's got what disease, and then try to see who's got more than one disease, and try to see if there's any correlation between the two. And that's what they did. So they looked at nearly 10,000 patients diagnosed with MPN over that 30-odd year period, and looked at another 35,000 patients who didn't. We could see that from this study, the risk of melanoma was about 2 times higher, and the risk of non-melanoma cancer was about 3 times higher. So this is really quite an increased risk. It's still not a huge risk, but it's definitely something that's there. Now, what could underpin that risk? We're assuming, and we'll talk a little bit, that it may be related to treatment, and the drugs that we've known for a long time, and I'll show a little bit of evidence about that, is hydroxycarbamide, a drug we've been using for more than 30 years. We know it's an extremely effective treatment for most forms of MPNs, but like any drug, it has potential risks and side effects, and one of them is increasing the risk of skin cancer. It might not just be that. Ruxolitinib may have an effect, I'll talk about that, but there's a little bit of suggestion there might be some other factors. So, for instance, this was a study from another sort of Nordic registry, which looked at the time people were diagnosed with their MPN, the risk of having another cancer. So this is at the time of diagnosis, before they'd started any treatment for the MPN. Oops. Okay, it's not going to show, but essentially what it showed is that there was an increased risk, just slightly, of certain other cancers, certain skin cancers like melanoma, and some other cancers as well, brain cancer. Very, very slightly increased risk, but it was there. And they postulated what could underpin that. Could it be that people who've got certain forms of MPN, even without any treatment, might be a bit immunosuppressed? Could it be they've got chronic inflammation? Could that contribute to it? Could it be that there's some gene mutations which could cause both? We don't know. Certainly people have tried to look into that. We haven't found any evidence one way or the other. But it's just to give you a little bit of an idea that the risk might not just be the treatment. It could be that there's other factors at play. Okay, I'm just going to talk briefly about what the risk factors are for skin cancer. So this isn't to do with MPN. These are just people who've got certain features like lighter skin color, particularly if it freckles or reddens easily. Interesting link to eye color or hair color. People who've had a lot of moles, people who've had a lot of sunburn, whether that's because they've worked outside, whether they've sunbathed a lot, been on sunbeds, anything like that, does increase the risk of skin cancer. I think probably most people know that by now. And then if someone's had a skin cancer before, they are at higher risk, or if they've got a very close family member who's had a skin cancer, and older age. Now, what are the risk factors for developing skin cancer for people who've got MPNs? Well, I'm going to show you in a bit. There's a hydroxycarbamide, ruxolitinib, and actually pipobromin, which we don't use very often, but does slightly increase the risk of skin cancer. How do we know this? Well, this was a European study that the Italian group led, and it looked at sort of nearly 2,000 people who had MPNs, and about a third of them had another cancer and 2/3 didn't. And they tried to see what the links were, whether there was any risk factors amongst the people who got another cancer. And they found that treatment with hydroxycarbamide, ruxolitinib, or pipobromin, the 3 drugs I just mentioned, did increase the risk of non-melanoma skin cancer. But interferon, anagrelide, and busulfan, so again, we don't really use busulfan much anymore, but we do use interferon and anagrelide, and they didn't seem to increase the risk of skin cancer. So that tells us that there's something about these drugs that potentially increases the risk. And what is it? And that's what the study is going to be, the methylate sub-study is going to be trying to look at. And the risk slowly increases over time. This was a meta-analysis of 10 studies, including the one I just talked about. They looked at 6,000 patients, and basically of the 10 studies, 8 seemed to confirm the link between non-melanoma skin cancer and hydroxycarbamide. So I think it's pretty clear that hydroxycarbamide does slightly, by about 2 times, increase the risk of skin cancer, non-melanoma skin cancer. How might it do that? Well, those are the capsules. What do they do? Well, what hydroxycarbamide does, the way it works, is it interferes with DNA synthesis. It's a ribonucleotide reductase drug, and that stops some of the key components, ingredients for DNA getting into the cell, and that's what we want, because in MPN, the cells are getting produced too quickly, and so if we can slow down the supply of DNA effectively, we can slow down the production of blood cells, and that works very well. But this enzyme, which it blocks, also helps the cells repair themselves if they get mutated. And what can happen if you're exposed to a lot of sunlight? The cells in the sun-exposed part of the skin, the face, the forearms, that kind of thing, do have a tendency to get more mutated, and therefore the combination of that increased mutation rate that we all have just by going out in the sunlight, combined with the impact or the effect that hydroxycarbamide has on the repair mechanism, does potentially increase the risk that mutations can occur and persist, and that can eventually lead to skin cancer. So that's what we think happens in hydroxycarbamide. And certainly my colleague, Dr. Nangalia at the Sanger Institute, has identified that there may be a genetic we can see a mutational link that might underpin all of this. So I think this is reasonably kind of clear. That isn't to say we should all stop taking hydroxycarbamide, because we know that in the long term, for the vast majority of people, the benefit of hydroxycarbamide greatly outstrips the potential risks. So let's now move to ruxolitinib, because we've seen from a number of studies that ruxolitinib does seem to increase the risk. This was a COMFORT-2 study, and again, some of the patients got best available therapy, so not ruxolitinib, and over 100 patient years, that's kind of the unit we look at, there was a rate of about 3 non-melanoma skin cancers, whereas those who got ruxolitinib, the risk was 6. So you can see the ruxolitinib seemed to double the risk. This was a study that a lot of the UK MPN specialists contributed to, and I'm very grateful. It was a really nice collaborative effort, and what we looked at was 90 patients who developed skin cancers whilst taking ruxolitinib. And most of them continued on the ruxolitinib. This is a complex diagram. I'm not going to try to explain it, but essentially most of them went down this arm, which is they stayed on the ruxolitinib. A few of them reduced the dose or switched to an alternative or stopped it. But what we found, so we weren't looking at how often they got skin cancers, because all these patients got skin cancers. What we were trying to do for this study was to see what kind of skin cancers people got. And it was the same kind of things we normally see, the squamous cell carcinoma and the basal cell carcinoma. But what we did seem to see is that some of the squamous cell carcinomas seemed to be a little bit more aggressive in the way they behaved. They potentially needed more treatment to try to get rid of them than people who weren't taking ruxolitinib from sort of historical comparisons. And so what that tells us is that people who are taking ruxolitinib, I think, need to be very vigilant to any new skin lesions which appear. And I'll talk about this in a second. And we need to understand what causes that to see what we can do to try to address that risk. Again, we know from the study that, from the data that Adam presented and others have talked about, ruxolitinib is an exceptionally effective drug for people with myelofibrosis, and we'll increasingly also use it for polycythemia. So we shouldn't certainly be getting rid of it, but we just need to try to mitigate the risk, to try to make sure we're not doing anything, or to try to make sure we're doing everything we can to try to reduce the risk for people who are taking it. So this is when I'm going to talk a bit about the sub-study. So how might ruxolitinib increase the risk of non-melanoma skin cancer? It doesn't work like hydroxycarbamide does. Hydroxycarbamide, we saw, affects the enzyme which helps DNA repair itself. We don't think ruxolitinib does that. But is there some other way that it could lead to more mutations? Or, and I personally think this is more plausible, but we don't know, if those mutations appear, so for instance, someone who's been on hydroxycarbamide before, those mutations were starting to appear at a small level, is normally what would happen is our immune system goes around basically fixing it or deleting any of those mutant cells. Now, we know that ruxolitinib can potentially lower our immune system a little bit, and so does that mean that if you've got those mutant-positive cells, does the ruxolitinib allow them to kind of grow? So this is our hypothesis, and this is what the sub-study is going to be trying to address. So I've got to say, I'm extremely grateful, I think all of us who are involved in this MPN Voice, because they have helped to fund this sub-study, and that's really, really useful. And even more than that, when we were trying to set up the sub-study, we sent out a questionnaire to the members of MPN Voice, and we got some really useful feedback. So again, really grateful for that, because that was extremely helpful in helping us to design this sub-study. And essentially what it is, it's for people who go on to the main study, so people who've got polycythemia vera, who are potentially going to be randomized, as Adam talked about, between ruxolitinib or best available therapy. There's an opt-in to do this skin sub-study to help us try to work out what it is about ruxolitinib that increases the risk. So what will happen if you do opt into it? So it is optional. Not everyone. So you'll be asked at enrollment if you want to sign up to this bit. You'll do 2 skin biopsies at the start of the study and 2 3 years later towards the end of the study. Now, a skin biopsy is not a bone marrow biopsy, I'd like to reassure you. It's a much smaller procedure. It goes very, very superficially into the skin, so just probably 3 or 4 millimeters into the skin. It takes about 5 minutes. And what we're doing is we're taking a small biopsy from the forearm, which is an area which is sun exposed, and another biopsy from the buttock, near where the bone marrow is taken from, which is a non-sun exposed area, and try to see if there's any difference at the beginning. In most people. And then we're going to try to see whether, at the end of the 3 years, there's any difference between the two, between the beginning and the end, in terms of the mutations. And so those samples will be sent to Dr. Nangalia's lab in Cambridge, which is already doing some really groundbreaking stuff at looking at this, to try to find out, Can we see mutations associated with ruxolitinib, as we've started to see hydroxycarbamide, or do we think it might be that second possibility that it reduces the immune kind of surveillance, as it's called, and that's how it works. So I think it's really important, and I'd encourage any of you who are being discussed or having the mithridate study discussed to consider going on to this sub-study, which is likely to open at the beginning of next year. Right, so that's sort of the main bulk of my talk. I've got a couple of slides. What do you do if you're taking hydroxycarbamide or ruxolitinib and you're diagnosed with a skin cancer? I think the first thing is do not just stop those drugs, because those drugs, if you stop them, potentially you can get quite nasty side effects, and also you increase risk of some of the complications. So you must discuss it with your hematologist. And I think the really important thing is the hematologist then discusses it with the dermatologist to see how worried the dermatologist is about the skin cancer. And then whether you need to change will depend a little bit about what MPN therapy you're taking, how serious the skin cancer is, whether this is a recurrence, and what your thoughts are, because I think that's super important. We don't have an answer. All we can say is we think these are the risks of doing this, these are the risks of doing that, and it's a discussion. In the interest of time, I'm not going to talk much about this, but what I would say is that all the JAK inhibitors do seem to have some risk of developing other cancers, including skin cancers. So I don't think we can say that we can just switch to fedratinib or momelotinib and that will get rid of the problem. I think it's more complex than that. We have to look at it case by case at the moment. So in the interest of time, I'm going to go through these very quickly. We know that there's an increased risk of skin cancer in some people with MPNs. We think it's probably mostly related to treatment, and you need to be aware of the risks. You need to inform your hematologist if you do get any of these new lesions, and also report it to your GP. Let your MPN doctor know if you do develop a skin cancer. And I think probably the most important thing I can say to you today is if you're taking any drug, well, even if you're not taking any drugs for MPN, but certainly if you are taking any of those drugs, is try to minimize your exposure to sun. And that is, covering up, wearing sunscreen, avoiding the midday sun, all the sensible things that we should all do. I think it's super important that anyone who's taking those drugs does that. I think that's enough from me, so thank you very much.